Next up to bat are going to be the muscarinic antagonists. Muscarinic antagonists are drugs that block the effects of acetylcholine. Their effects mimic the sympathetic nervous system actions because the parasympathetic system is being turned off. Some muscarinic antagonists have the common ending of trimine, but many do not. Unfortunately, you're just going to have to memorize these. I really do recommend making flashcards. Now, I've already introduced one of these drugs, atropine, as a way to block excess acetylcholine through muscarinic antagonism. Remember our farmer example. In the farmer example, there was too much acetylcholine at the synapse. We introduced some atropine to block that muscarinic receptor so that acetylcholine has nowhere to go. Then we also gave some pralidoxime if it was short enough time, and that hopefully regenerated the enzyme to break down our acetylcholine. So, what are some of the characteristics of atropine? Well, atropine is a prototype drug. It has a long half-life and it crosses the blood-brain barrier. Homatrimine and tropicamide are similar drugs but with shorter half-lives and therefore are more useful in certain clinical situations. All three of these drugs produce mydriasis and cycloplegia and can be used clinically to dilate the pupil during a fundoscopic exam. And what is cycloplegia? Cycloplegia is the loss of accommodation from paralysis of the small ciliary muscle in the eye. Atropine actually can be used to treat bradycardias as well. And finally, remember that atropine we just talked about is going to be used to treat acetylcholinesterase inhibitor poisoning. The next drug, benztropine, is a muscarinic antagonist that's used for the treatment of Parkinson's disease. Let's quickly review some neurology. Parkinson's disease is due to the loss of dopaminergic neurons and excessive cholinergic activity. So how does benztropine help treat Parkinson's? Well, benztropine is going to blunt the excess acetylcholine, which contributes to the symptoms you'll see like rigidity, akinesia, tremor, and postural instability. So the mnemonic for benztropine is park my benz, so benztropine is used to treat Parkinson's. You may encounter glycopyrrolate on your anesthesiology rotation. Glycopyrrolate is used perioperatively to reduce airway secretions and sometimes orally to decrease drooling and peptic ulcer formation. It cannot cross the blood-brain barrier, so it'll block muscarinic receptors in the periphery. This is why glycopyrrolate exerts its effect on the GI system and the respiratory system. Hyoscyamine and dicyclomine both act primarily on the GI system. These are both used as antispasmodics in the treatment of irritable bowel syndrome. Ipratropium and tiotropium are used to reduce bronchial secretions in the treatment of asthma and COPD. It's often given in combination with albuterol. Remember the mnemonic, I pray I can breathe soon. Now, does ipratropium work the same way as albuterol for the treatment of asthma? Well, no, each drug has a different mechanism of action. Albuterol works on the beta receptors, while ipratropium works on the muscarinic receptors. So we'll discuss albuterol in a bit, but for now just realize that ipratropium blocks muscarinic 3 receptors, which is going to prevent that bronchoconstriction and allowing people with asthma to breathe better. Many individuals suffer from overactive bladder. Oxybutynin, solifenacin, and tolterodine are all used to reduce bladder spasms and urge incontinence. What's the difference between sympathetic and the parasympathetic system on the bladder? The sympathetic system will relax the detrusor muscle, while the parasympathetic system is going to activate that detrusor muscle, causing bladder contraction. Now, if we antagonize or block the muscarinic receptors with these 3 drugs, then we can help reduce bladder spasms and hopefully help relax the bladder. And lastly, we have scopolamine. Scopolamine acts in the central nervous system and is typically used for motion sickness. Remember, when you have all of these muscarinic antagonists, you're going to block or antagonize the effects of acetylcholine. And when this happens, you're going to decrease the secretions from the body or block the wet picture. As I mentioned before, atropine is a muscarinic antagonist. We've also discussed its use in acetylcholinesterase inhibitor poisoning. Remember our farmer example. So we're going to discuss atropine just in a little bit more detail because atropine is a major USMLE Step 1 drug. Now, it's easy to remember atropine's effects because you can think of it as the opposite of the parasympathetic system. Remember, our parasympathetic picture was the wet picture. Now, how is atropine going to affect the body? In the eye, it causes pupil dilation and cycloplegia. And what's cycloplegia? Remember, it's that fancy term for paralysis of the ciliary muscle within the eye, which is going to result in a loss of accommodation. So a person experiencing cycloplegia would not be able to focus in on close objects. In the airway, atropine decreases airway secretions, and it'll also decrease gastric acid secretion. In the gut, atropine decreases motility, and in the bladder it decreases urgency. Now we've covered quite a bit of material so far. You may be wondering, what's the easiest way to remember all of the effects of atropine? My recommendation would be look back at our discussion on the G protein linked second messengers. If you know what activating each receptor does, then you can figure out what blocking each receptor does. Atropine simply blocks the muscarinic receptors, so you'll get the opposite effect as activating a muscarinic receptor. Thinking like this will allow you to study less and remember more on test day. Like I just said, atropine acts the opposite of the parasympathetic system, so it'll act to mimic the sympathetic system here. Remember, the parasympathetic system causes bodily secretions, and atropine will block these. Okay, so what do we have here? We have a free question. Yes, that is right. This is an extremely common test question. So hopefully I have your attention here for the next few minutes because I'm here to get you the maximum points on test day. Now, what happens during an atropine overdose? Well, an atropine overdose would block the muscarinic receptors too much, causing the opposite of dumbbells, or remember our wet picture. Atropine toxicities can be remembered by the following mnemonic: hot as a hair, dry as a bone, red as a beet, blind as a bat, and mad as a hatter. So in other words, an atropine toxicity presents the opposite of our dumbbells mnemonic. You'll see an increased body temperature due to a decrease in secretions, including sweat. You'll see a rapid pulse, dry mouth, flushed skin. And why would we see flushed skin? Well, it's because you'll get peripheral vasodilation to compensate for that increased body temperature. You'll also see cycloplegia, which we talked about, constipation, urinary retention, and disorientation. Now, why disorientation? Well, to remember disorientation as an atropine side effect, you can think about the association between Alzheimer's disease and decreased acetylcholine. From neurology, you need to remember that Alzheimer's disease presents with neurofibrillary tangles, or widespread cortical atrophy, and also a decrease in acetylcholine levels. Atropine decreases the amount of acetylcholine binding by blocking those muscarinic receptors, thus giving Alzheimer's-like disorientation. Is anyone here into gardening? If so, you may have heard about Jimson weed, which is also known as devil's snare. So this plant, seen here, acts similarly to atropine due to its anticholinergic properties. So the story goes that if a gardener is handling this weed and then touches their eye, they'll experience mydriasis. Remind me again, what is mydriasis? Oh yeah, it's pupillary dilation. Now I know we're talking about a simple garden weed, but I think we can get a little bit deeper on the subject just to reinforce what we learned earlier. So tell me, mechanistically of course, how does an anticholinergic weed such as this cause mydriasis? Well, let's pretend you're on a safari in Africa. You're riding along on your tour bus when out of nowhere a lion jumps out at you. Are your pupils going to constrict, which limits your vision, or will they dilate, allowing you to see more of your environment? Well, your eyes will most likely dilate, says common sense. This means that your sympathetic nervous system is going to be activated. It's going to kick in. Remember, sympathetic is fight and flight. So, if your pupils dilate when your sympathetic system is activated, then on the other hand, that means your pupils are going to constrict or cause miosis when your parasympathetic system is activated. So, your parasympathetic system is going to release acetylcholine. So, I'll explain what I just wrote here. Acetylcholine is going to be your primary postganglionic neurotransmitter of the parasympathetic nervous system. In the eye, acetylcholine binds to M3, muscarinic 3 receptors, causing pupillary constriction, which then leads to miosis. So now it's time to bring this discussion full circle. If we have an anticholinergic agent, such as atropine or jimsonweed, we're going to block the acetylcholine effects on that M3 receptor. Therefore, we're going to block the constriction. And if we block M3 receptors and block constriction, the pupil sphincter is not going to contract, causing mydriasis. So who knew a weed could be so much fun? I really want to emphasize the concept of muscarinic antagonism toxicity, specifically atropine toxicity, and that's going to be such a high yield topic on test day. Don't be surprised if you encounter a question prompt that has a dry patient that's hot, red, blind, and possibly disoriented or confused. And when you think of this kind of a patient, I want you to immediately think atropine toxicity until proven otherwise. Let's run through a question together. Let's say on the USMLE, the prompt describes a 34-year-old female who presents to the emergency room with nausea and diarrhea. She also reports dizziness, weakness, paresthesias, and this strange loss of deep tendon reflexes. Upon questioning, she reports that she ate at a Japanese restaurant last night and ordered pufferfish. Now there's quite a few tip-offs in this question prompt. Have you guessed what's wrong with this patient? She is suffering from tetrodotoxin poisoning. Tetrodotoxin exerts its effects by blocking voltage-gated sodium channel depolarization on both nerve and cardiac tissue. So it's going to block sodium-gated channels. Now this effectively prevents propagation of action potentials without really affecting the charge of the resting potential of the neuron. Although this is a nasty little toxin, its presentation on the USMLE will be pretty limited. So symptoms are going to be very similar to food poisoning. The nausea, vomiting, diarrhea, weakness, all very non-specific findings that you might find in normal food poisoning scenarios. Treatment is also the same, just supportive. It's the same as food poisoning. You can't really do much once you actually have tetrodotoxin poisoning. However, there are a few symptoms that just don't belong with normal food poisoning. Normal food poisoning does not present with nervous system problems, such as dizziness, paresthesias, or even this loss of a deep tendon reflex. So this should be your first red flag. The second red flag should be the word Japanese. You should think to yourself, why would the USMLE test writer include Japanese in the question prompt? Well, tetrodotoxin poisoning results from improperly prepared pufferfish, which happens to be a delicacy in none other than Japan. So I'm guessing that any question involving tetrodotoxin on the USMLE will talk about pufferfish, Japan, or some sort of mechanism of action question. If all else fails, just remember that tetrodo kind of sounds like Tokyo, which is in Japan. Flash quiz time. We're going to take a quick break from toxins and see if you are paying attention to our discussion on muscarinic antagonists or the muscarinic blockers. A female patient complains of urinary urgency from frequent bladder spasms. Which muscarinic antagonist can reduce urgency in this patient? Well, the main ones that I'm trying to get at are oxybutynin, solifenacin, or tolterodine. These drugs act as muscarinic antagonists that are going to treat urinary urgency. So make sure you're familiar with all of the muscarinic antagonists on the list and know how each is going to be used clinically.